webinar is about COVID, the COVID vaccine and sickle cell. So we have 3 guest speakers, and we are going to start off with Dr. Perla Eleftherious, COVID and hemoglobinopathy. Dr. Perla is a hematology consultant from UCLH. She's the lead consultant at UCLH for the hemoglobinopathy team. Dr. Perla.
Lovely. Can you all see my slides?
Yes.
Yes.
Great. Okay. Can you still see them?
Yes.
Fantastic. Okay, so good afternoon, everyone, and sorry about this delay. We had some technical problems, and I'm really very happy to see loads of people joining us today. So feel free to, as Matti said afterwards, to ask us any questions you have. So this is obviously a webinar which we have set up with sort of, relatively short notice, as things are progressing very quickly, as you know, with this pandemic, and they're changing very, very rapidly, because we have recognized that there are some people around, sickle cell patients and non-sickle cell patients, so generally, who still have concerns about the COVID vaccine. And a lot of these concerns are the result of potentially inaccurate or unhelpful information which is circulating around on the social media or amongst ourselves talking to each other. So therefore, hereby we want you to feel that at the end of the webinar you have received accurate information, so that you for yourselves make a decision about whether to have the COVID-19 vaccine. So there is no, obviously, a lot of literature in terms of sickle cell disease and COVID-19 for understandable reasons, because this is a new virus. But we know from a lot of research in the past and clinical experience with patients with sickle cell disease that viruses generally predispose sickle cell patients to develop complications, so acute chest syndrome or severe crisis, for example, the influenza vaccine. Oops, I can't move my slides. That's it. So yes, that's the first example. So very well reported in the literature how influenza, so the flu viruses in sickle cell disease are associated with an increased risk for hospitalization and acute chest syndrome in patients with sickle cell disease. So, and recognizing this being potentially a problem, so this new virus called COVID virus in our sickle cell patients, we have formed, so us, including myself, so a national group of doctors and nurses who belong to the National Hemoglobinopathy Panel. We have formed an established kind of collaboration with each other, which has been going on since March last year. So within this collaboration, we have been meeting through video conferences or teleconferences once every week. And we have been reviewing guidance that has been issued by NHS England, and we have been advising back NHS England and patient support groups about specific COVID-19 risks to our patients with sickle cell disease. And within this work framework, within this collaboration, also hospitals across the whole country have been sending to us anonymized data to this working group in order to look at the number of patients with sickle cell disease affected by COVID-19 and what happens to people with sickle cell disease who get the virus. And you can see here from this graph that gradually, so we've been recording these numbers since beginning of March, April 2020, and you can see how gradually the number of cases that we have accumulated has increased. Now, these numbers represent numbers of patients with a combination of different hemoglobinopathies, so not just sickle cell disease. So sickle cell disease, thalassemia, and other rare anemias, but the majority of them have sickle cell disease, and I'll show you another slide in a minute. So up to around sort of mid-February, the total number of patients with red cell disorders and COVID has been about 630, as you can see. In terms of the ages of the patients, you can see that the majority, both in during the first wave of the pandemic, so early last year, as well as in the second wave, have been between 20 and 30 and 40, you could say. So the majority of our patients affected by the virus are young, essentially. But of course, you can see that other age groups have had the virus. So it affects all ages across the spectrum. But it's just from this we can say that the younger patients have been are just more in terms of how they've been affected. And you can see, oops, this doesn't project very well, but you can see from this pie chart that from all the patients that I have just shown you, from the just over 600 patients who had the virus for the last year, or since March 2020, when we started recording the numbers, are patients with sickle cell disease. And the majority of those patients with sickle cell disease are homozygous SS patients. So 64% of all the patients have SS disease, 16% have SC disease, and some others have the other types of sickle cell disease. And you can see that, so the grey bar here the grey bars represent the number of patients during the first wave, and the red bars represent the number of patients during the second wave. And essentially you can see that during both pandemic waves, the majority of the patients affected have been sickle cell patients, and the majority of all those sickle cell patients have been homozygous SS patients. Now, from all those patients that we have seen contracting the virus so far, 66% needed hospital admission during the first wave, and 43% during the second wave. So you could say that about half of them with both waves needed to come to the hospital for treatment, so they were unwell with the virus. In terms of the age and gender distribution of the inpatients, so of those who were severely affected by the virus and needed to come to the hospital for treatment, we can see that, again, as I showed you earlier, the majority of the patients are in the age groups between 20 and 40. And what we can see here is that there is a slight female predominance. So there are slightly more women than men, which is a little bit contradicting what we see in the general population, in that males have been reported to be more, there are more patients with COVID than women in the general population. I mean, there isn't a great difference here, and I don't think we can conclude anything in particular from this one. In terms of transfusions, in those patients who caught the virus and had to come in to be treated, the majority didn't need any transfusions, and about 20% needed automated exchange transfusions, and about 10% needed a top-up transfusion. This gives you an idea as to what proportion of our patients who came into the hospital because they were severely affected, because they were ill with the virus, needed intensive care admission and non-invasive ventilation, as we call it. So about 10% of those patients with the first wave, and roughly the same, so 8% with the second wave, needed to go to the hospital, stay there, and have non-invasive ventilation. In terms of intubation on the during the intensive care unit admission, about 6% needed intubation and mechanical ventilation with the first wave, and about 3% with the second wave. So you can really, the message so far is that overall, thankfully, our sickle cell patients are kept well and they manage at home, and they're not particularly, you know, severely affected, but there is a proportion who are affected and can become very unwell. And these pie charts now tell you that the majority have indeed recovered. So that applies to both waves, first and second wave. So 90% recovered with the first wave. 1% needed hospitalization, and sadly 9% did not actually make it. And with the second wave, again, the majority recovered. A little bit of a higher proportion needed hospital admission, so about 30%. And we had less patients, thankfully, who didn't make it. In terms of those patients who didn't sadly make it through, the majority of them were indeed sickle cell patients. So again, don't forget that those data I'm showing you represent you know, all the patients with rectal disorders, but the vast majority are sickle cell patients. So now from this data, which basically shows you that there is a suggestion that sickle cell patients are slightly more affected by the virus than the general population. Can we quantify the relative risk of COVID in sickle cell disease? So we know that we know the data in our national hemoglobinopathy registry show that we have about 15,000 patients with sickle cell disease across the UK, and the majority of them are concentrated in London, and some of them are in the Midlands. We do, taking this into account, as well as other international kind of, you know, collection of data that has been shared with us from and published, for example, from France and the States, perhaps we can draw some conclusions about this relative risk. So, for example, the France cohort, that was a publication from September last year, shows that actually, so from the 83 patients that they included in this study, 20% were admitted to the intensive care unit, and 2% did not make it through. So overall, compared to the general population risk, they didn't conclude actually that sickle cell disease appears to carry an increased motility risk. The States, however, that was a bigger study, October 2020, that was the publication date, included more patients, about 180, about 70%, so a bigger proportion, were hospitalized, and 7% did not make it through, which is pretty much what we have seen here in the UK as well in terms of risk proportion. So from this data, we can say that the risk for severe disease course, so for sickle cell patients when they get the virus to become unwell, is probably higher than in the rest of the population, or in the population who don't have sickle cell disease. And again, it's very difficult to draw rigid black and white conclusions because there's so many other confounding factors to affect how severely a person can become after how severely ill a person can become after catching the virus. There are factors such as ethnicity, obesity, and other comorbidities such as diabetes, high blood pressure, asthma, etc. But what we can see from here, which is a busy slide, but with a simple message, is that if you take into account our national hemoglobinopathy registry and age distribution, and if you take into account the general UK population morbidity and mortality, what we can say is that our patients with sickle cell disease, which belong to the younger age group, so between 80 and 50, have a slightly higher risk of becoming unwell compared to the people of the same age group who don't have sickle cell disease. And this slide tells you that it doesn't really matter the gender, so female and males almost equally affected. I mean, I did say earlier, perhaps slight female predisposition in our sickle cell cohort, but overall 50-50. And also what these slides tells you is that it doesn't matter what the underlying genotype of your disease is or how badly you have been affected by your sickle cell disease in the past. That is to say, even if you had a mild sickle cell disease so far in your life, that still can be can change, and it can, regardless, you can become unwell from the virus if you get it. So this is what the slide here shows you. So overall, it's too early really to say whether patients with sickle cell disease do really significantly worse than the general population when they catch the virus. But data which we saw here so far, and sort of similar to the American data, is suggesting that the risk of sickle cell patients becoming very unwell if they catch the virus is higher than if you don't have sickle cell disease. So that's why adults with sickle cell disease should be considered clinically extremely vulnerable and follow government guidance about shielding. Now, this is copied and pasted from one of the patients that I have treated in the intensive care unit. This is a patient under Dr. Dekreuk usually, but has been treated on ITU at UCLH, and I was directly involved in her care. This is a written testament from a survivor of COVID, and I want to read it out for you. I was scheduled to receive treatment for my kidneys due to having lupus and sickle cell disease at the University College Hospital.
Hello, sorry, it's the interpreter here. You're going to have to slow that right down, please.
I'm sorry, of course.
Thanks.
Yes. Upon arrival, I had a COVID test which came back positive. It all went downhill from there. My health rapidly started to deteriorate. My already weakened body was now having to fight this deadly virus. I experienced headaches, diarrhea, shortness of breath, fatigue, high temperature, irregular heartbeat, and my blood pressure kept rising. I was moved from a COVID ward to ICU where I could be closely monitored. From here, I was literally fighting for my life every day. It was becoming more and more difficult to breathe without the oxygen masks because my lungs were filling up rapidly. ICU was so depressing. I was away from my family with death all around me, fighting for my life all alone. I underwent a lot of treatment to overcome the virus. The doctors really looked after me. They kept explaining to me how difficult my case was because of the kidney disease, lupus, and sickle cell. I had all the odds stacked against me. I was admitted in hospital for 6 weeks, 5 weeks of which were spent in ITU. I received many treatments, blood transfusions, plasma exchanges, etc. This virus is not one to play with, luckily for me. This virus is not one to play with. For me, luckily, I made it through the other side, but many people haven't, and we must take COVID very seriously. And I thank her for sharing this. So the next few slides, I'm just going to really concentrate on other aspects of sort of real life testaments again, so similar to the one that I've shown you just now. I'm sure a lot of you might be aware of the Caribbean and African Health Network. This network has a lot of valuable information on their website, and if you haven't heard of it or if you haven't looked at the website recently, please go and have a look. So I've just picked a couple of just sort of key highlight information. So one of them said, one of those highlight messages on the website says that vaccine hesitancy is the highest, so 72%, among Black people. This is in the UK. Also, another copied and pasted essential information. In the UK, Caribbean and African people are more likely to suffer disproportionately as a result of transmission, and which leads to worse levels of morbidity and mortality from COVID-19. So this is generally people of African and Caribbean origin. And this is really data from the National Statistics Office, which backs up what has been put on this website, which shows you very clearly that the African Caribbean COVID-19 rate per 100,000 is the highest. You can see that it's 538. So the chair of the Caribbean African Health Networks says, we know there was limited uptake from the Caribbean and African community in the vaccine trials and uptake of the flu vaccine. This would be the same for the COVID-19 vaccine, unless there is an increased immunity engagement and discussions to myth bust. And the chief officer of this says that our health hours have been running weekly since the 2nd of May in 2020, and we're pleased to engage the Black community in the trusted space where Black doctors from our community would honestly discuss why they received the vaccine and why they would encourage Black people to receive it, considering the disproportionate impact of COVID and underlying clinically vulnerable disease health conditions, which makes the community more vulnerable. I just wanted to say it as it is, as it appears on that side. So remember, COVID vaccines in sickle cell disease, they are very important. They offer very important protection against the coronavirus. They are safe in sickle cell disease and generally. Vaccines have a long history of saving lives in sickle cell disease. Look at the pneumococcal vaccine, for example, and the flu vaccine. So any concerns about the vaccine must always be weighed against the potential impact of getting the virus. And here, the next two, I'm not going to read them out, but these are healthcare professional stories from BAME, from the BAME community at network, and these are people who work at UCLH and they have published their stories. Here, for example, you can see Rashida, midwife and co-chair of the BAME network. You can see that she says she works in an environment, she says, where she could be exposed to the virus, and I felt it was my duty to protect my family and my patients and to lead by example. Josephine, maternity site manager, co-chair of the BAME network. I grew up in Africa and have had vaccines all my life, and I've made sure that my children have always been vaccinated too. We're fortunate to have been offered the COVID vaccine so quickly. Critical care manager. She was hesitant. She didn't know much about it. She spoke to one of the consultants at UCH, and she says, being able to talk to somebody honestly about my fears and anxiety and having someone listen without any bias or prejudice was refreshing. She acknowledged my fears, but emphasized the level of protection that it could offer. Our specialist nurse, clinical specialist nurse and Red Soul Network education matron in the Hemoglobinopathy Coordinating Centre in North Central London, Bernadette, she says, I had the COVID vaccine to protect myself, my loved ones and my patients, so we can get back to life, hanging out and hugging. And if you're worried about faith leaders endorsing the COVID vaccines, here is the information that you need to have. So British Islamic Medical Association, the Chief Rabbi, the Sikh Council, the Church of England, Anglican, Methodist, Salvation Army, all faith leaders are endorsing the COVID vaccination and have been posting videos and statements on public media and on their websites. So please get vaccinated. This will greatly decrease your chance of getting infected or suffering serious consequences of the illness. And I hereby want to thank you for listening, and any questions I'm more than happy to answer here now or later.
Thank you, Dr. Perla, for that presentation. There is one question which I will read out. I'm not sure who posed that question, and the question is there any particular reason why people with SS are more affected than people with SC?
Yes, I mean, the very good question. What we have seen is that we have more people, more patients with SS actually having or contracting the virus. In terms of, just because we have more SS patients around as well, I think this represents the numbers, you know, it's proportionate to the numbers we have. So we have more SS patients than SC, and therefore we will see the virus in more SS patients than SC patients. But what we have seen actually is that it affects, in terms of how it affects the patients, it doesn't really differ so much. And this is one of the messages I wanted to say, that regardless of whether of your phenotype, of how you know, mild or severe your disease was in the past, we have actually seen patients with SS and SC patients equally being affected from it. It's just we have more numbers because we have more SS patients.
Thank you very much for that, Dr. Perla. If there's any more questions, then we can leave them to the end, since we are running way behind. So I will say thank you once again, Dr. Perla, and then we're going to move on to Dr. Corrah, and he is going to talk about how the vaccine works, how the vaccine was made so quickly, and hopefully answer a lot of questions from that perspective. Thank you, Dr. Perla, and over to Dr. Corrah.
Right, just bear with me. And thank you, Maisha, for that introduction. I'm just going to share my screen.
I didn't actually say, Dr. Corrah, that Dr. Corrah is an immunologist working in Central Middlesex Hospital. Thank you for participating in this webinar.
Okay, again, I'm hoping that you can all see my slides. Great. So yes, thank you again for the invitation. I'm Tumena. I'm an infectious diseases consultant. I actually work at Northwick Park Hospital, which is one of the worst hit centres during the first wave. And again, I'm very grateful for the opportunity to come and talk to you a bit about COVID vaccines. So what do we know about COVID? Well, COVID-19 is an infectious disease which is caused by a newly discovered coronavirus. It was first identified in China in December of 2019 and has rapidly spread worldwide. The World Health Organization, or WHO, declared the COVID-19 outbreak a public health emergency of international concern on the 31st of January 2020, and then declared it a pandemic on the 11th of March 2020. Just to give you a scale of the pandemic or the problem that we face, as of the 2nd of March 2021, globally, there have been over 113 million confirmed cases, over 2.5 million confirmed deaths, and cases recorded in 223 countries. A bit closer to home, as of the 2nd of March this year, there have been over 4 million confirmed cases and over 120,000 confirmed deaths from COVID-19. That's about 1 in 1,000 of the entire UK population has already died after being infected with coronavirus during the pandemic. Vaccination is the most effective way to reduce these deaths and severe illnesses from COVID-19. So a little bit about how vaccines work generally. Essentially, you're given a small amount of a harmless form of a disease. Your body then makes antibodies to fight it off, essentially arming your immune system. If you then encounter the disease again, your body already has antibodies to fight the disease, so you then don't get sick. So vaccines have been around for centuries. They've played a significant part in improving the health of the nation. We have vaccines to thank for eradicating diseases that previously killed millions of people, such as smallpox and polio. We also know the importance of maintaining high vaccine coverage, a good example being outbreaks of measles seen in the UK and the rest of Europe, when vaccine uptake fell due to false claims linking the MMR vaccine to autism. So how are vaccines made? Well, typically, this process takes many years, with vaccines going through safety trials in smaller numbers of volunteers before being tested in larger numbers of volunteers, checking that volunteers that receive the vaccine are protected against the disease of interest compared to those volunteers that did not receive the vaccine. Then all the data is gathered from these studies and sent to a national regulatory body. In the UK, that would be the MHRA, or the Medicines and Healthcare Products Regulatory Agency. The agency then checks that the vaccine is safe by going through all the data that it has received before finally giving approval for its use. Once approval has been given, the company making the vaccine can then begin manufacturing the vaccine in large numbers for use. I'm pleased to say that this process changed for COVID-19. Because of the seriousness of the pandemic, there was a coordinated international effort with no cost spared. There were thousands of volunteers, and the different phases were run at the same time instead of sequentially. Scientists and doctors worked all hours and at speed, with regulatory bodies reviewing the data in real time. Also, manufacturing happened at the same time as testing was taking place. This meant that the vaccines were ready for use and rollout as soon as approval was given. This is why COVID vaccines were approved so quickly. I think I must stress here that no corners were cut, and these vaccines are very safe. So where are we with COVID vaccines globally? Well, there have been 90 vaccine candidates, 243 trials, and 12 approved vaccines across the world as of the beginning of this month. 3 have been licensed in the UK. That's the Pfizer vaccine, the Moderna vaccine, and the Oxford vaccine. All of these 3 are based on the spike protein, which is a protein on the surface of the coronavirus, which it needs for infecting cells. The Pfizer and Moderna vaccines use messenger RNA technology. I'll tell you a bit about that. Messenger RNA is a sequence of genetic code which tells our cells what proteins to build so they can function. Scientists have developed a synthetic version of COVID-19 spike protein, messenger RNA. When this is injected into our bodies, cells read it as an instruction to start building spike protein, which then prompts the immune system to make antibodies and protects against future COVID-19 infection. The Oxford vaccine uses a viral vector technology. In this technology, a harmless virus is altered by introducing the code for COVID-19 spike protein. The harmless virus then transports that code into our cells, which then start to produce the protein. This triggers an immune response, essentially priming our immune system to attack the real virus later. None of these vaccines contain the COVID-19 virus, and therefore they cannot cause or infect you with COVID-19. Right. Well, what do COVID vaccines do? Well, in trials, these vaccines have reduced the numbers of people who got COVID-19. The Pfizer trial involved about 44,000 people, with half getting the vaccine and the other half receiving a placebo. 170 people got COVID, 8 in the vaccine group and 162 in the placebo group. That is a vaccine efficacy of 95%. In other words, there was a 95% reduction in cases of COVID-19 in the vaccinated group compared to the unvaccinated group. The Moderna trial involved some 30,000 people, with half getting the vaccine. 196 people got COVID, 11 in the vaccine group and 185 in the placebo group, giving a vaccine efficacy of 94.1%. The Oxford vaccine trial involved about 24,000 people, with half getting the vaccine. 131 people got COVID-19, 30 in the vaccine group, and 101 in the placebo group, giving a vaccine efficacy of 70.4%. It is important to stress at this point that COVID vaccines cannot give you COVID, and they cannot guarantee that you will not get COVID. So who was in the trials? Well, a range of people volunteered. I should stress again that there's no reason to think that vaccines work differently in different ethnic groups. People from Black and minority ethnic groups were involved in the trials. Across all three trials, about 10% of the volunteers were actually Black. So vaccine rollout in the UK started on the 8th of December 2020, so a few months ago, with the NHS currently offering the vaccine to those most at risk from coronavirus disease. Patients with sickle cell disease and thalassemia are in priority group 4. Hopefully, most of you dialing into this forum have now been called for your vaccine. I really think it's been a really great achievement that over 20 million people have received the first dose of vaccine as of the 2nd of March. That's 20 million people receiving their vaccine in the space of 3 months. That's really an achievement. Well, are the vaccines safe? Well, the short answer is yes, the vaccines are safe. Some people may experience side effects after the vaccine, but these are usually mild and much less serious than developing COVID-19 itself. Common side effects may include tenderness at the injection site, getting a fever. This usually happens within 48 hours of the vaccine and usually goes away within 48 hours as well. Flu-like symptoms such as feeling tired, getting a headache, joint and muscle aches. It's fair to say that these side effects reflect the normal immune response to the vaccine. It is very, very rare to have a severe allergic reaction or anaphylaxis to the vaccine. The MHRA has now collected data from well over 20 million vaccinated people, and the data reassuringly shows that only 168 cases of anaphylaxis were recorded with the Pfizer vaccine, and again, only 105 cases of anaphylaxis were recorded with the Oxford vaccine. Well, it's a bit of further good news for you. We now have data showing that the vaccines are as good in the real world as they were in the trials. And the Pfizer vaccine was 72% effective after the first dose and 86% effective after 2 doses in healthcare workers. In adults aged 80 years and over, the Pfizer vaccine had an effectiveness of 70% after the first dose, rising to 89% after 2 doses. In adults aged 70 years and over, the Pfizer vaccine had an effectiveness of 61%, and the Oxford vaccine had an effectiveness of 73%. Additionally, a single dose of either vaccine was 80% effective at preventing hospital admissions, and a single dose of the Pfizer vaccine is 85% effective at preventing death from COVID-19. So these really are impressive statistics. Not only does it reduce your chance of being admitted to hospital, it also effectively reduces your chance of dying from COVID-19. Right. A bit about COVID in BAME groups. Well, we know that COVID has had a disproportionate effect on certain BAME groups, with people of Black ethnicity being twice as likely to die from COVID compared to people of white ethnicity. Yeah, I think Perla mentioned it before. We do know that there is vaccine hesitancy. Before the vaccine rollout, a poll conducted by the Royal Society of Public Health showed that 57% of respondents from minority ethnic groups were likely to accept a vaccine, compared to 79% of white respondents. Since the vaccine rollout, uptake has been lower in the Black group compared to the white group. In people aged 80 years and over, some 92% of the white group had already had the first dose of vaccine, compared to only 61% of the Black group. Again, in the 70 to 90-year-olds, that figure was 86% in the white group, compared to 55% in the Black group. I think it's important to stress here that it is by no means too late for people to have the vaccine, and we need to continue to encourage and inform even those who have already turned it down previously. This is certainly why I attend meetings such as this one, where I can champion the benefits of vaccination and address misinformation face-to-face or transparently. So giving you a lot of information about the vaccine so far, but it's important that even after we're vaccinated, that we continue to protect others, hence the government guidance on washing your hands, wearing a mask, and making space between individuals. I would like to end on what I think is a pretty powerful slide showing the benefits of vaccination. Polio was a devastating infection, as you can see from this picture, from 1950. But thanks to vaccination, its spread has now almost completely been eradicated across the globe. My one big hope is that COVID-19 vaccines will have a similar effect on COVID-19 in due course. That's it from me. Thank you very much.
Matthew, you are on mute.
You're on mute.
Thank you very much, Dr. Corrah. I do have some questions, but I am going to save the questions for after the next presentations, because they fit more in with those presentations. So if you've got any questions for Dr. Corrah, then please add it to the chat or ask later on in the question and answer session. But thank you so much, Dr. Corrah. That was very informative, really interesting. Thank you. So the next presenters or speakers, we are going to listen to a few people who have actually had the vaccine, find out the reason why they've had the vaccine, and how it impacted on them. So the first person that's going to speak is Mr. Calvin Campbell, our co-host. Calvin, if you can introduce yourself and then take it away.
Hi, my name is Calvin Campbell, Chair of Red Cells Are Us, and I also have Sickle Cell SS. And the reason why I decided to take the vaccine, I'm going to be totally honest, I don't take the flu vaccine. Initially, I wasn't going to take the vaccine and I was unsure about it. I'm being honest here. So I don't want people to think that, I understand people's hesitance and the fact that people have misgivings and some are historical. And some of those things are based in fact, but a lot of those things are based in rumor and things that they pick up on the internet and social media. And so the main reason why I chose to take the vaccine was, I had it 2 weeks ago, because I have my 94-year-old mother-in-law staying with us. I have 4 grandchildren, all under the age of 7. And I spend a lot of time going back and forth to the hospital. So to protect myself and protect others, I chose to have the vaccine. Because I thought to myself, if going back and forth to the hospital and being out and about, and I picked up the virus and then passed it on to someone more vulnerable than me, a 94-year-old, I couldn't forgive myself for that. So for that reason, I chose to protect myself and protect those around me. And why I urge people to take the vaccine, especially if you have sickle cell or thalassemia, because it's not just you you're protecting, it's the people around you you're protecting. You're protecting the people that you care about most. And we're vulnerable, and we know that if we were to contract it and become really unwell, it's not good for us as it is. So, and then protect the people around you is of utmost importance. Because if I think the problem with the vaccine is that a lot of people listen and share things on social media, and the most dangerous tool in the modern age is WhatsApp. WhatsApp is probably one of the most dangerous things for spreading misinformation, because on a daily basis, honestly, on a daily basis, I get sent between 6 to 9 bits of information, either articles or videos, of people telling me why I shouldn't have the vaccine, and because the government is doing this and they're going to be doing that, and so on and so forth. And it's the same for blood and organ donation within the Black community, which is why historically blood and organ donation in the Black community is incredibly low. Blood donation is about 1.5%. Organ donation is less than that. And if you're Black or ethnic minority in this country and you have organ failure, the odds are you're going to die. If you're vulnerable and you have sickle cell and you get the vaccine, you have other problems, the odds are you're going to get very sick and probably die. Now, you cannot care about yourself. That's fine. That's your choice. Absolutely your choice. And if you don't want to take it, fine. But then what about people around you that haven't made that choice, haven't made that decision, aren't in a position to say, I'm cool with that? And if you got the virus for whatever reason and pass it on to someone that is more vulnerable than you or people you care about, how would you feel? So for that reason, I decided to have the vaccine. And in April 22nd, I'm going to have the second shot, and I have no problem with it. And the only side effect I got from the vaccine was tiredness and fatigue, which lasted a week. After that, I was back to my beautiful self. Young, gifted, and Black. No problems. And all the stories and all the misinformation that people told me that would happen, none of that happened. Zero. On the day I got the vaccine, I asked 5 or 6 of my friends, who a mixture of sickle cell and thalassemia patients who also had the vaccine, would they mind posting the fact that they've had the vaccine? And I took their pictures and I posted on our social media page to show people that we all had the vaccine and nothing happened to us. No monsterism. I didn't grow an extra head. I didn't suddenly, feel the need to bite someone in the neck, and nothing. Zero. I may have had an extra craving for cheese and onion crisps and jelly babies, but that's it. Nothing happened to me. I look as good today as I looked before I had the vaccine. So when I see someone posting a picture of me, of a video, and telling me, and there's someone speaking eloquently about the risks of having the vaccine, my first question to them is, where did you get that from? Who sent it to you? A friend sent it to me. Who sent it to your friend? Oh, a friend sent it. I know the person who sent it. Who made the video? I have no idea. Most of the videos are American, and I'm not being funny. If I'm going to take advice about the vaccine, it's not going to be from an American. With the second highest death rate in the world, are you seriously telling me that's who I should take my advice from? That's like asking a pedophile childcare advice. And yet people are sending me this information as if it was gospel, as if it was fact. Sign this petition, sign that petition. You work for the NHS, tell people not. Why? You have no idea who sent you this information. You downloaded it off the internet, social media. You don't know the person, who made the video, who sent you the information. A friend sent it to you, a friend of a friend of a friend. And that's the advice you're taking? If someone sent you advice anonymously, telling you to invest in stocks and shares on the moon, would you do it? No, you wouldn't. Why would you then take advice about something so serious as your health from complete strangers, from someone you have no idea who they are? There's no way to verify the information that they're giving you. And most of the information can be dispelled like that easily. Every single day, honestly, I go to bed and I wake up and my WhatsApp is full of people telling me, Calvin, you got to read this. Calvin, you got to watch this video. It's incredible. It's really moving. It's powerful. It's someone that had the vaccine, and look at them. They're in a terrible state. You have no idea who the person is. Someone knocks on your door and said, you know what? I'm selling insurance. You're going to buy it? No, you don't. So why would you take your information from just social media, from a post pulled from wherever and shared with you on WhatsApp, of all places? We're on a day-to-day basis, like I said, since it started, I have lost count, honest to God, lost count of the amount of material I've been sent. And not one of them has convinced me that I shouldn't take the vaccine. Like I said, nothing happened to me. Nothing happened to the people I know who have sickle cell and thalassemia. And if anything was going to happen, it would happen to someone like me, who has spent more of their life in hospital, sick. I've had things at the top of my list of things to worry about. It isn't whether or not the vaccine is going to give me monsterism or do whatever. I've had to go through things that you couldn't believe. And yet I'm going to take an advice from a complete stranger that I shouldn't have the vaccine. That is just crazy. You've heard expert testimony, people showing you real evidence, facts about why the vaccine you should take the vaccine. All the points, every bit of information. Tell me anywhere on social media, the internet, WhatsApp, where you've seen anybody present any information like this in such detail. None of you can. Nobody can. It's usually just some person telling you, oh, you know what, I woke up and I felt really bad. I had a splitting headache and now my nose is running, I'm going to run to the hospital. And you believe that. You take that as gospel. I have no idea why. I'm not telling people how to live their life, but if you had to make a choice, and a choice made on fact, okay, made on a decision based on proper knowledge, make that choice based on that, not on misinformation spread through social media and WhatsApp, not through misinformation spread by someone who hasn't had the vaccine, who's telling you that this will happen to you. And you say to me, have you had it? No. Well, then how do you know? I've had it. So when people ask me what happened, nothing. I felt tired for about a week and I feel wonderful. Do I not look wonderful to you? Do my skin not look, do I not look 25?
Thank you.
And that's my point. The vaccine is not just about protecting yourself. Honestly, it's about protecting people around you, people that are vulnerable, and everybody probably has somebody around them. If you thought about it, who's more vulnerable than you, whether it be a parent, grandchild, child, whoever. And then ask yourself, how would you honestly feel if you got the virus and then made someone who you care about more than your life unwell? I get on great with my mother-in-law. Why would I give her the virus?
Thank you, Calvin. Thank you. Thank you for that. The next speaker is Stephanie, and Stephanie's going to give you a her personal journey with COVID and the vaccine. Over to you, Stephanie.
Okay, thanks, Matty. Can everyone hear me? Because I don't know if it's, I'm on the computer now, so I don't know if it's working. Is it, can you guys
Yes,
hear me?
yeah, we can.
Yeah,
Well, I
no?
can. Yes, I can.
Okay, cool, that's fine. That's right. Hi, everyone. I am Stephanie, and I'm the vice chairwoman. So I'm Calvin's assistant, technically, for Red Cells Are Us. I have sickle cell, SS, and I'm also a midwife. So I'm in the unique position of working in the NHS and also being obviously extremely vulnerable. I've been working from home since last April because I got COVID last March. And I think I was one of the first people at Whittington with sickle cell to actually be like diagnosed with COVID. It was one of the worst experiences of my life. I've had a stroke and everything like that. And it was just, what it was is, and I think this is what people need to understand, you can get sick really quickly. What happened was I was at work that day. I was feeling a bit unwell, but I was like, okay, it's fine. Got through my shift, got home. And all of a sudden, like maybe a couple of hours later, I started feeling shiverish. So I thought, oh my God, maybe I've got an infection. My mum had to help me out of my room and everything like that. And I was shivering for a good 20 minutes. After that, I became unresponsive. It just went from 0 to 100 so quickly. I wasn't responding anymore. I could not talk. I was finding it hard to breathe. So my parents had to like just rush me to A&E. And by the time I'd gotten there, my temperature was through the roof. It was like 39 degrees and stuff like that. I could not walk. My parents had to like just drag me into the hospital. Thankfully, once we got into the hospital, they were quick. Everyone was just rushing around doing what they needed to do. I didn't end up in ITU, thankfully, but it was the fact that we didn't even know what it was, because back then it was really early, so they weren't sure if it was an infection, but they asked me, oh, do you have any symptoms? So I was like, yeah, I had a cough and a sore throat. And then they said, okay, we're going to treat you as suspected COVID. And while I was there, so I was there in hospital for maybe like 5 or 6 days, and I was really, really ill. Like I had to have like a transfusion that night because they were like, if you don't have blood, you might not make it. Had the blood and then started to feel better. I got discharged and everything like that. But what I wanted to say is that also with COVID, with me, when I had it, it then started triggering a sickle crisis as well. So I was having my regular medication. And then eventually I got discharged and I went home. And the recovery process was, so I had it in March. I think I started to feel human again in June. So that's like 3 months later. And I'm in my late 20s. So I'm still relatively young, and it just took forever to get better. And it was that was just even the physical aspect, the emotional aspect, the mental aspect. It's still till like almost a year later now, I still get like, sometimes when I go to hospital, if it's for like an appointment or something, I still feel a bit traumatized. I still feel, let me say, what happened? When I was in May last year, I had to go to hospital for like, I was in pain. So I went into hospital, and then I saw that I had to go through A&E, and I had flashback back to March, and I started panicking. And I think it's just, those are the things that people don't really talk about. Yes, there's the physical aspect of having COVID and recovering from COVID, but then there's also a mental aspect that needs to be discussed, and people need to be, have a safe space to talk about it, because it can, it does affect all of us, or it can affect all of us. And you probably know someone, even if it's not you, you probably know someone who's suffered from COVID. So that's why, for me, having that experience, that's why I decided to get the vaccine. But I will be honest with you as well, like Calvin, I was a bit skeptical to have the vaccine. And I think it was because, like, I normally get the flu vaccine every year, so it wasn't that. I just felt it was too quick. Like, I felt, how you've done all of this in a year. That's what made me scared. And then obviously, yes, you do get so much WhatsApp, videos, calls about, oh, don't take this and don't take that because there's, fetal DNA or something like that in the vaccine. So I spoke to Dr. Emma, I spoke to Matty, and I spoke to other nurses as well, and my colleagues who have had the vaccine. And I did my own research. And that's the one thing I do advise people, you need to do your own research. Google is free. Just type in the vaccine or whatever, or type in what's happening and actually do your own research. Don't listen to hearsay, because most likely they will steer you wrong. As Calvin said, most of this information is not, it's not evidence-based. But yeah, I did my own research, and then I got the vaccines. I got my vaccine end of January. And it was really easy. It was a really quick process. My side effects though were a bit different from Calvin. So I think I got that evening, I got like chills, but it didn't last that very long. I had a sore throat. My arm was hurting for a few days. And then it was the next day, it's like for me, it felt like I'd been hit by a truck. Like I was in so much pain, but it wasn't as bad as COVID. So I was like, I can soldier through this. But then by the time it got into like maybe 2 days later, I was fine. So I am getting the second dose when I think April, I will be getting the second dose. And I just think my advice is to, I did it for myself. I did it for my sister who got COVID in January. Those are the factors that, made me decide to do it. And because I want to go outside, I want life to now start getting back to normal. And I think the vaccine is one of the ways that society will get back to normal. And I think if we all want to, be able to see our loved ones again and, talk to them face to face and hug them and, do all the things that we used to do before COVID, the vaccine is one of the ways out of that. So that is my advice for people, and just do your own research and try not to listen to hearsay, because everybody's got an opinion, but not everybody is like medically trained. And I would always say, talk to your consultants, talk to other people who have had the vaccine and who have sickle cell or thalassemia. That also might help. But yeah, that's my story for today. Yeah.
Thank you very much for that, Stephanie. Another good story and another strong voice. So the next person I'm going to hand you over to now is Femi, for him to tell you about his own story. Over to you, Femi.
Thank you, Matty. Hi, good evening, everyone. Thank you for your time today and attending. I'm Femi Ekinrenade, and I also have sickle cell and have taken the vaccine. And hearing from my other two friends who have been online and explained why they took it, my reasoning is actually slightly opposite to Calvin's. Calvin had alluded to not wanting to infect other people and protect himself and protect the people around him. Whereas for me, I am the most vulnerable person in my household. I simply live with my sister alone. So in terms of her being fully able-bodied and healthy and I having sickle cell, I seem to be the higher at risk person. So, oh, sorry, Gold. Okay, I saw the hand go up. Okay, yeah. So my reasoning for taking it kind of stemmed from understanding that when I want to go out into the real world, as the world is going to reopen, being at home for such a long period of time has definitely had some form of a mental negative effect on myself. And it's also sort of increased the level of fear. So my feeling is that as a sickle cell person, we are already more aware of the negative dangers within our environments, whether it is physical danger from the cold, or it is a biological danger from dirty food or unclean environments, because we understand our immune systems are not as strong. So during COVID, this paranoia kind of increased within me, and I started to notice just the little things, like being a vulnerable person. When somebody handed me an item during COVID, for example, I suddenly found myself thinking, when was the last time you washed your hands? I'm not sure I want to take that from you. There was another incident. I went to the supermarket and it suddenly hit me. Everybody is wiping their baskets, and absent-mindedly, I forgot. Suddenly I went into, oh my gosh, I've just gone and made myself at risk of catching COVID. And on a very personal level, I'm a little bit OCD. I like clean. I love bleach and fairy liquid, my best friends. And when I was cleaning up and washing plates within my own household, me and my sister, whom she too is isolating because of me, I tended to look at these plates like, how did you wash this? This is not as clean as what I washed. So I even went to the extent of not using the same cutlery and plates as other people. Now, I'm aware that this is clearly my OCD just beginning to start to trigger. And I'm feeling that with all the secondary information in the TV and the media, the sensationalize it, this is what drives it. So when looking at the vaccine, I decided to try and look for data in this vaccine to try to understand why I should take it. And that's where I found that there was a lack of information. Even today, Dr. Corrah has showed us some information on advocacy, but understanding how the vaccine works is possibly for me more about understanding how the vaccine works within my subgroup. So furthermore, I am Black African, I have a long-term illness, and I have sickle cell. Generally, when vaccines are being developed and tested, and especially in the situation which of this was done very quickly and to the, well, as fast as possible, what I would have liked to be able to see is within the total sample size of the testing of the potential vaccines, how it performed among people in subgroup A of Black people, second subgroup, people with long-term disabilities, and a third subgroup of people with hematological, sorry guys, disorders. And I would have loved to be able to research and find that data, but I found that that data was not particularly forthcoming or available, or I am unaware of where to find the data in order to make this analysis. So as a result of that, I started and I spoke into Matty asking about sickle cell. My thought is to protect myself, how is that best? It's either through a vaccination or the ability to recover. I'd seen articles online about sickle cell people having caught the vaccine and recovered. And until Stephanie had chimed in earlier, I was possibly a little ignorant to the depth of effect and danger it does have on a sickle cell person. I didn't feel that with the stories I saw of a 6-year-old boy recovering in the, why would that would indicate to me that sickle cell people are able to recover from it. So my risk of catching it or my fear of catching it should be reduced. But in all honesty, what I started looking at is looking outside and other people. I kind of found that there was a lot of other people who, as Calvin had said, were alluding to mantras of, we don't want to take a vaccine, or I don't feel COVID is real. And I started to understand and speak to my friends and people who were in my social groups, which are the groups I will be rejoining once I leave isolation. And I realized a lot of them do have different views on whether they need to be vaccinated. So as a probability person, my understanding is, as a sickle cell person or as any individual, you can only control the factors and the variables that are within your control. So from that was where I started to decide that maybe taking a vaccine and getting a level of advocacy, whether 70 to 90%, depending on the vaccine, is me taking the best available current option I have to protect myself against other people. Because my fear is not myself. I feel I isolate very well, if not maybe a little too much. But so the risk comes from the outside world. And because you cannot control individuals, and I feel that nobody catches COVID on purpose. Everybody feels that they're being, well, not everybody, but most people will feel they're being careful. Most people feel that they're going to protect themselves. But when people have different levels of immune systems like us in sickle cell, I note within my own household, my sister's idea of protecting herself does not equate to my level of protecting myself. So even within my household, I isolate partially from my sister because I don't believe that she fully is taking it seriously. And in that mentality, you would have to look at the rest of the world to understand that if people aren't necessarily taking this or have alternate views, the only thing you can do is protect yourself. So my decision to take the vaccine was very much a selfish-driven decision in order to protect me from the externalities and the risks. What I did find a challenge, though, which I would maybe like to comment towards the doctors and the medical people towards this, and maybe the members of the sickle cell societies and information boards who are trying to help the growth of the vaccine uptake within BAME groups, is I found that a lot of the information I searched for from the hemoglobin, gosh, I can't say that word, hemoglobinopathy UK register, the sickle cell group, and the NHS, they put out a letter. Well, let's not call it a letter, we'll just call it an information sheet on sickle cell and how it affects and its effects and the vaccines. And I found that the information given is just very top line. In fact, I would almost say that there is an element of dumbing down in the information provided to us. And I understand as a marketing and communication person, you communicate to the mass as possible, you simplify what is said. But I do feel that as a BAME community, it intrinsically makes us feel that we are being communicated to as the lowest common denominator methodology, and not given the depth of the data required for us to make these decisions for people who wish to make a data-driven decision. Now, the general tables of people, sample groups of people who create vaccines, they're tested on generally healthy people. They're generally tested on middle-class Caucasian males. There's some level of, what do we call it? Inclusivity within the sample selection for people who are, well, different ethnicities and different types of people. I would have liked to see the sample data for within my ethnicity and my subgroup pulled out to convince me as a sickle cell individual that I am able to take this, because the genericness of the information just made me feel uncertain about whether it actually applies to myself. And I think that's where I will sort of close on this, because I don't really want to repeat too much on the reasonings why, because Calvin has covered a lot of, there's a lot of tertiary information where people are choosing to act on, which is not substantiated. And Stephanie has also covered the effects of sickle cell on us as individuals. So my point of view is that those are very external views. As a sickle cell person or as an individual, you can only protect yourself, and you are only aware of your own actions and can trust your own actions. So at that point, the opportunity cost of not taking a vaccine is to either fall ill, go through it, and go through what Stephanie has, potentially risk dying and recover, or you can take a vaccine and protect yourself to a level of 70 to 90% against falling ill and ending up in hospital. Or the third choice is to just stay in isolation forever. And I didn't think the third option was really something I wanted to do. So I think I'm just going to conclude to end here and say thank you guys for your time and for your thoughts.
No, thank you for your time and thought, Femi. Very interesting, and some points that we as medical practitioners do have to take on board when thinking about producing literature. Yes. So thank you for that very much. And I do have a question for either you, Stephanie, or Calvin. I've got a question from Kay, who has asked, for those with sickle cell who have had COVID, the COVID virus, so that probably just means Stephanie, did they also have painful crisis, or was it more the usual symptoms of the COVID-19? I think that's to Stephanie.
Yeah, so for me, it's like it just simultaneously happened. It was like, I think my body's trying to fight to survive. And then the crisis just started. Like, I must have got into hospital, and then I was just in so much pain everywhere. And so it just started simultaneously. My temperature was through the roof, and then the pain started. And so I had to get the regular dosage of like morphine. They had to first give me the first dose when I got into the hospital, because I was in so much pain. They had to give it to me IV. And then after that, it was my normal subcutaneous injections. But the pain was, for me, it was like one of the worst pains I'd ever been in regarding my sickle cell pain. It felt heightened, but then I'm just wondering if that was just because I was so ill. So that's what it felt like. And it might have just been a normal crisis, but it just felt really bad. But yeah, it was really intense, and it was very, very hard.
Can I just say that for me, pain-wise, I'm in pain all the time, and so there was a slight increase in pain, but not to the extent that I ever felt that I needed to go into hospital, and the fatigue was more of an issue. But like I said, that passed within a week.
Yes, and maybe just a calling for myself, though not suffering the side effects of the vaccine that I experienced were actually fairly light. For the first day when I took it, I just had a slight sore arm, sleepy and a little bit tired. It was on days 2, 3, and 4 that it increased, where I had shivers, flu-like feelings, definitely a loss of appetite, a sore throat.
And that's because the COVID's in it, isn't it?
And a headache.
Huh?
And
in the vaccine?
Technically, I don't think there's COVID directly in the vaccine. From my understanding, there are altered/edited viruses or something like that, but not an actual COVID viral. So you don't run a risk of catching COVID from the vaccine, which was something that medical practitioners can correct me if I'm wrong. But so I'm not quite sure what caused it, but on day 5 to 7, I started to return to normal, feel less tired. But as Calvin has said, the major challenge I find with it is the listlessness and tiredness that you experience. So I found that taking the vaccine, I had to have a lot more help from my family and my sisters to help me prepare my meals and do my daily tasks for that week while I was recovering from the vaccine. So anyone thinking of taking it should try and put measures in place that when they have taken it, how they can be taken care of if they're extra tired.
Thank you for that. I was just wondering, I'm not sure who we heard about asking about because it's got the virus in it, but there's absolutely no live virus in the vaccine. And Dr. Corrah did explain that during his presentation. And I just wonder if Dr. Corrah is still with us and if he could just highlight that again and just answer that question.
I'm still here, Matty. Thanks for that. Yes, let me stress again that there's three vaccines have been licensed for use in the UK. 2 are being rolled out. The Pfizer one on the 8th of December, like I mentioned. Oxford one has been used since I think it was the 4th of January. And neither of those vaccines is there any live COVID at all within them. And the vaccines themselves cannot give you COVID. I stress again, you cannot get COVID from the vaccine.
Thank you, Dr. Corrah.
Can I just say very quickly, Matti, that there were loads of questions in the chat and I've been trying to sort of catch up and answer. So maybe at the end, if any are directed to Dr. Corrah or me and they're not clear in terms of the answers, we're happy to take them, yes?
Thank you for that. Thank you, Dr. Perla. So we will move on to our final speaker of the session, and that is Dr. Arne Dekreuk, And Dr. Arne is the lead haematologist for haemoglobinopathies at North Middlesex Hospital. Thank you, Dr.
Yes.
Arne.
Hello, thank you, Matti, and many thanks to Red Cells Are Us for inviting me to share some thoughts with you today. So yes, my name is Arne Dekreuk. Just in the scope of the meeting, after working in one of the London hospitals that was also very badly affected with COVID, after about 10 months, I thought I was probably immune to the virus and actually sort of possibly dismissed the severity until Christmas Day, and I actually got COVID-19. I've got no risk factors as far as I know. I'm just under 50, but I was probably, I felt the most ill I've ever felt for many years, with some long COVID-like symptoms that I'm actually still struggling with a little bit. So I would say I possibly underestimated it after a little while. I decided to have the vaccine as well, because the recommendations are that despite the fact I probably built up an excellent immune response against the virus during the first 2 weeks, the vaccine would give me an extra booster. So I had my vaccine about 5 to 6 weeks after COVID. And again, that was a slightly unpleasant surprise because for about 24 to 48 hours, I had very high temperatures, rigors and aches all over. But I'm here today feeling incredibly well, and it felt like I've done the right thing. So that's a bit of personal background. Matti asked me if I could, spend a few words on myths and facts. And as opposed to the other speakers today, I would like to do a little bit of psychology with you, talk a bit about the sort of background of where myths come from, and lastly, I've sort of selected some of the most, I would say, intractable rumors I could find, which I would like to present on the screen. And for a live audience, it's always easier to ask people to raise their hands to see whether they agree with the statement or not. But let's see how we can do it interactively via this medium. I'm just going to share my presentation with you. If you bear with me. Can you all see the screen? Excellent. So yeah, facts versus myths. Yes, bit of theory maybe, but in our thinking and in our decision making, it's important to realize that on the one hand we have feelings and emotions. On the other hand, we have got rationality. Feelings and emotions are, as it suggests, things we feel, and that makes us either scared or angry or happy. Rationality is based on digesting facts, drawing your own conclusions, following research or following reliable information. We can make these decisions either consciously by, let's say, actively thinking about it. A lot of it also takes place in the background and are sort of non-conscious decisions. And to give you a little bit of an example, I thought I'll throw this statement at you. In itself, when you read the statement like this, you should really have the vaccine because it gives you 90% protection at COVID-19. That's just a neutral statement. And well, anyone sort of reading that can have their own feelings about it. Now, what would happen if you get this message in your face presented like that? Would that change your view on the sort of the meaning of this statement or not? I think it might do, because you have a sort of association with the person giving you the message and other things they may have said that you do agree or that you don't agree with. Another example, it was already mentioned before, that people tend to think that Americans have a different way of presenting things or a slightly different healthcare system, perhaps. So how would you feel if the person reiterating this message was Donald Trump? Or exactly the same message, and these two faces may look familiar to you, if your doctor, your consultant, tells you that there is 90% protection against COVID-19, or if it's a family member or someone very dear to you. So in a sort of our decision making and the things that happen in your brain and how you sort of consider the facts, it's very sort of dependent on where the message is coming from. Calvin already mentioned the fact on one of my favorite slides about sort of media. I believe it's coming up next. No, it will come after this slide. The other thing is sort of the impact of events. So if I tell you this, my neighbor's friend had a vaccine 3 months ago and nothing has happened since. I mean, that is absolutely fantastic news, but it's not really the kind of story that you say, well, hang on, you know, Arne told me this, his neighbor's friend had a vaccine and nothing happened. That's not the kind of story you tell. What may be more interesting is if my neighbor's friends had a vaccine 3 months ago and she was really unwell the day after. That's the kind of story that you may pick up and tell other people, because it has some kind of impact on you, that something happened. Here's another one. This is a real example, by the way. My neighbor's friend had a vaccine 3 months ago and now she's been diagnosed with breast cancer. This is the kind of thing that spreads very easily. And it was probably true that the neighbor's friend had a vaccine as one of the earliest people, and that she's now been diagnosed with breast cancer. But obviously, from a scientific perspective, there's absolutely no link between the two. But just because someone tells that story and has a large impact, it tends to spread via social media, via mouth by mouth, or it might even make it to the news. So this is also the psychology behind how does a myth start. And this is a slide I really like, sort of the effect of media, recognized experts over time. So in the 1980s, leading scientists were generally sort of believed to be the experts. And that sort of changed over time towards media experts. And now we've got Karen on Facebook. And I think it's very true what Calvin said. It is the way you digest your information, where you get it from, what sort of you remember best, if that makes sense. So this is very much, as far as I'm concerned, the way well, rumors or myths start. I'm not going to talk for too long, but I have selected a few statements I've found or I've heard, or one of patients of mine have asked me, and I just want to see. And I'm not sure whether we can do sort of a raise hand kind of thing, or in the chat box, a few people can say yes or no or agree. And the first one, and I think the most relevant one for tonight, and I'm also curious to see what my colleagues think about this one, is this one. COVID-19 vaccine can cause a sickle cell crisis. Is that a myth or is that a fact? Is there anyone yeah, I'm not sure whether we can sort of, you can't really raise hands altogether, but maybe people can sort of say yes or no. I can just bring the chat up here. No. Well, maybe I can't. Oh, hang on, there it is. Myth, myth, myth. Yeah, I can see lots of myths. And then can I ask one of the experts, Perla, what is your view?
Yes, thank you, Arne. As a statement, this is a myth, okay? But there is some degree of truth there. Like medicine, there is never yes or no. There's always, you know, a gray area, yes, but or no, but. So I have seen a patient who developed a crisis after having the vaccine. So it's possible, but this is nothing new with this vaccine compared to any other vaccine. Exactly. So if you have a vaccine, a flu vaccine, and you get a sore arm, we all know, and you guys know more than anyone else, you who have the sickle cell disease, how any irrelevant to your disease pain can actually, you know, trigger a crisis. So this is what it is.
That totally agree, and I think you can sort of reason it. If let's say you have, and again, some people say that if you've had COVID recently, you're more likely to react to the vaccine because your immune system is already triggered or has been triggered. If, let's say, you develop a temperature of 39 or 40 Celsius after a vaccination, yes, that like an infection with a high temperature can actually trigger sickling. And it's not actually in the guidelines, but we have had some chats with our patients where we say, well, just when you have your vaccine, if you're nervous about it, make sure you drink enough and have some paracetamol. Don't let it, happen, your high temperature. But yes, occasionally it can trigger something, but obviously it's not true that having the vaccine will guarantee give you a crisis. That's absolutely not true. This is a favorite one. Who's come across this one? Let's open the chat again, see if some people say true or false. Yeah, you can see someone grew an extra. Yeah, so this was a very sort of, strong rumor, especially about the Pfizer vaccine. I think that it enters your cell and changes your DNA. Obviously, it's not true. I'm not an expert, not a virologist, but I'm sure Dr. Corrah can comment on that. But viruses can enter your cells and change your DNA, but vaccines don't. I mean, vaccines can go into your cell, but it won't internalize into your DNA. So it's not true that a vaccine changes your DNA. And sort of, well, this has been covered by Dr. Corrah already, so I'm just going to skip this one. But it's not true that the COVID vaccine is experimental. I mean, it's new, obviously, because COVID-19 wasn't there, a year and a half ago. But the technique of the vaccines, all of them, is not new. It's not experimental. It's just this particular virus that's new. And as such being built into existing types of vaccines. This is one I touched upon during the introduction. I've already had COVID-19, so I don't need a vaccine. Maybe not really a myth. Dr. Corrah, can you maybe feedback on this statement, because I think it's an interesting one.
Yeah, it is an interesting one. The honest truth is that we just don't know how long immunity will last naturally, and I think that's why the recommendation is that it's important to get a vaccine dose. Putting in simple terms, you might see it as boosting your immune system. Giving you further protection, but even then, we don't know. I mean, we know that in a minute we're getting 2 shots of vaccine to increase the protection you get, but again, we just don't know whether we're going to need a 3rd shot in a year's time or sooner. It's just early days for now. We can only work with what we have, and currently the recommendation is that it's certainly sensible to take the vaccine even if you have had COVID. It may be that it turned out to be something like flu, that every year we need a slightly different a jab to protect us against the circulating strain. I mean, it's just too soon, I think, to be able to say with anything with great certainty. It's pretty fluid at the moment, I'd say.
Yeah, I think that's very true, isn't it? So, I mean, as I said, I chose to have the vaccine because that's what the general recommendation is, and it sort of feels like better safe than sorry, as some of the others said as well. And Stephanie chose to have the vaccine as well, despite the fact that she had COVID very badly before. This one is also rather intractable. I didn't see on your slides, Dr. Corrah, that the COVID-19 vaccine has got microchips created by Bill Gates funded research into it, but were you speaking the truth, or is there actually a hidden technology behind it?
I always speak the truth.
I mean, this is, I mean, and there's still a lot about the sort of 5G network causing coronavirus, and it's all a myth. I find it fascinating how strong this belief is sometimes and where these rumors come from. And just to come back to social media as well, I mean, one of the things I think that's particularly, I would say, well, sort of the evil bit of social media is as you know, I mean, getting likes and views on your channel or whatsoever can actually be very lucrative. So let's say if I state something on Facebook or on YouTube that's incredibly true, but well, frankly, incredibly boring, as in I've had the vaccine and nothing happened, I'm not going to have 2.5 million likes, and I'm not going to be a what do you call it? Well, there's a word for it, like not a genius, but one of those people who gets very high up in the rankings and in YouTube. However, if you post something really stupid and you get 1 or 2 million followers, some people will just use that in order to get their attention. And obviously, if you have 2.5 million followers for a particular statement, that statement is very likely to make it high in the ranks, and people will actually start believing it. So that's yet another disadvantage of how social media works. I think there's another one of those. And that's also an interesting one that I've heard a few times, including some of my colleagues at work who said, well, the virus mutates so fast. I mean, we've heard the government sort of say about these things, and we've had the recent warnings of the Brazilian variant and the South African variant, and yet another lockdown with regards to the new variants. So is it worthwhile having this vaccine if you know that new mutations come into place? I think, again, I can't see the chat, but I'm sure Dr. Corrah can comment on this statement.
Yeah, I think it's important that we have the vaccine. What again, like I said, this is a very fluid world. Of the variants that are out there, we know the virus mutates. I think you mentioned the South African variant, the Brazilian variant. There's also the so-called Kent, or as I like to call the UK variant. And currently there's a lot of talk about whether or not we might need to develop new vaccines down the line. What I will say is that what data we do have coming out, we know that the Oxford vaccine and the Pfizer vaccine in the real world are protective against the dominant strain in the UK now, which is the Kent strain. So although the vaccine was designed using the, if you like, the original coronavirus spike, the virus has mutated away from that a little bit, but the current vaccine seems to offer a great amount of protection against the UK variant, certainly.
Yeah. Thank you for that. This is another one that, again, I must admit, in America, maybe we are a bit more with both feet on the ground in the UK, but this made it into the newspapers in the United States, and has been at least quoted to me on a few occasions. And there's an Alabama died hours after receiving the COVID-19 vaccine. Maybe just ask the group chat again what your view on this statement is. Let's see if I can bring up the chat again. Yeah, well, Mark, yes, I think that that was my first thought as well. How did she die? Was she run over by a bus, or what happened? The typical, oh, hang on, I've just pressed a few wrong buttons here, I apologize. When you look into the story in more detail, it's actually totally unknown what happened. Most certainly not related to the vaccine, if she died in the first place. But it's just the sensation of a young nurse dying hours after the COVID-19 vaccine that made it to the headlines via social media. And it was actually one of the family members, apparently, who made the claim and then could not verify any of the data. But again, it's a very toxic rumor. And if you think of my example earlier, bad news spreads more quickly than neutral news or good news. That's, I think, how human beings work. I mean, we like to worry, and we do not necessarily like to be reassured, and I think that's sort of psychology behind myths. People do like to worry. Think of any sort of big news event or whatever else is happening. People are inclined to worry. This is another one. So someone published a sort of semi-scientific paper on the internet saying that the COVID-19 vaccine has been proven to cause infertility in 97% of its recipients. I can tell you the truth, that is obviously a myth, because first of all, the vaccine hasn't been long enough around to come up with such an accurate figure. Secondly, there was absolutely no truth on the literature cited by this person. It relates back to some obscure trials in the 1960s, and then made up made up data. But again, a news story that via the unofficial routes made it very quickly to the headlines in social media, and it was actually one of my patients who pointed this out to me when she asked me, I've heard about the infertility risk. I still want another child, so I'm not having the vaccine. And I said, sorry, I just don't understand what you're saying. And then she gave me the article. So it does almost look like a proper publication. Really, again, there is an awful lot out there. I've reached the bottom of my slide and also the end of the thoughts I wanted to share with you. So thank you for listening, and I'd like to give the chair back to Matti.
Thank you so much, Dr. Dekreuk. Thank you.
My pleasure.
That was very interesting. Very interesting. There's lots of those myths that I'm sure we've all heard. We have all heard, and that are circulating around. So we've had some questions on the chat, which Dr. Perla has been keeping an eye and answering for me or for us. And let me see. Oh, there was a question. Is it true that the virus is 4 to 5 times more contagious than cold or flu? Which we know it is, particularly the new variant. And then I think most of them have been answered by Dr. Perla, but if there is anybody who wants to raise a question now, then just please put up your hand.
Or you can just unmute yourself briefly to ask the question if you wish.
Hi, Matty, it's Bernadette.
Hi, Bernadette.
Hi, I saw a question earlier and I don't know if it got answered in the group or to everybody, but somebody was asking about travelling abroad after the second vaccination. From what I know, they haven't decided when people can come out of shielding, because I think it will depend on lots of things, not just your own personal vaccination status, but how we are rolling out across the country, what's happening in other countries in the world. But I'll let the doctors answer, but I don't think we have that information yet, so when we'll be free or getting out of the country if you're shielding.
Yes, I would agree, but Dr. Corrah, would you like to take that?
I think I just remind everyone that we're still in lockdown, and I know that our Prime Minister sort of laid out a roadmap about when we'll get out of it. My understanding of the roadmap is that June the 21st is the date when we're officially out of a lockdown. So I assume that means that's when we'll be allowed to travel. But we mustn't forget that, you know, we're talking about ourselves. What about other countries? There will be rules and regulations there that need to be met. I read something in the papers this morning which made me sort of smile. I think it's Malta has said that once you've had 2 vaccines. Cyprus, sorry, to forgive me. You're allowed to visit them. Well, that's great, but we kind of wish to leave the UK at the minute. So I think all these things, time will sort of tell. And I'm sure there will come a point where we will be allowed to travel and visit other places. And I'm sure that time will come quicker with the vaccines. But I'm afraid it's something that we can't answer for now, and will be guided by vaccine rollout and government telling us what the rules are in due course.
Dr. Corrah, there was a question about animal products in the vaccine, to which I said there are no animal products in the vaccines, but I think, can you please confirm that?
Yeah, I saw that question. There was a question about chimpanzee products, and I completely agree that there are no animal products in the vaccine. I think the slight confusion, or if you like, the twisting of facts there is that the Oxford vaccine is very much based on the viral vector model. And as I said in my talk, it requires using a harmless virus and inserting the genetic code for the viral spike. Well, the harmless virus that was used is an adenovirus, which is a common cold virus, and they used one that infects chimpanzees, which meant that it doesn't infect humans at all. But yes, the short answer is that no animal products were either vaccine.
I see, Kay, you have your hand up?
Yes, I did. Just wanted to ask 2 questions quickly. The first one, is there anything you can do as a sickle cell patient to boost your immunity, such as taking vitamin supplements? I know obviously a healthy lifestyle, eating well, goes along with that, but is there anything specific that can be done? That's my first question. And the second one was, there are 3 different vaccines available in the UK. Is there anyone that's specifically better, for want of a different word, for use in treating sickle cell patients specifically? And can you request which vaccine you want when you go to have your vaccine? So those are my 2 questions.
Thank you, Kate. I can have a go, and then Dr. Corrah or Dr. Dekreuk can fill me in. So the answer to your first question, is there anything to boost your immune system? All those things that we've been talking about, or your doctors have been talking to you about, generally, still apply. So as you say, healthy diet, exercise, your vitamin D supplements, your folic acid. Now, if your question, Kay, is in relation to, is there anything in particular to do to boost my immune system to avoid the risk of catching COVID, or avoid the risk of, if I catch the COVID virus, to become unwell, then the answer is no. The only thing to do to boost your immune system good enough to prevent you becoming unwell from the virus is the vaccination. Okay, and then the other question, sorry, I had the answer in my at the tip of my tongue and I forgot. What was the question? I even had prepared the answer and I forgot.
It was which, is there a specific
vaccine? Oh yes, indeed. No. So all vaccines are equivalent, simple answer. The efficacy is very similar across the board. We are collecting data across the country in terms of, our sickle cell patients having which vaccines, and we're looking into the, how they react to them, if there are any side effects from them.
To find physical data.
But we do not have any preference. There is no scientific reason to expect any difference on the efficacy of any of those vaccines available whatsoever. And I think in terms of whether you can choose, my impression is that you can't, and whether you are offered, that's pretty much what you can have. But this is, I think, what it is now. So Dr. Corrah can feel.
I'll take the second part of that question. You're absolutely right that there are 3 licensed vaccines for use in the UK, but actually only 2 have been rolled out. That's the Pfizer vaccine, followed by the Oxford AstraZeneca vaccine. Now, again, the message is clear. Both vaccines had good efficacy in trials, and in real life data, they're both effective. So I think you should take whichever vaccine you're offered. As things stand, I don't think that you're given a choice. You get invited to a vaccine, and you will get either one of those 2 vaccines. But remember, they're all equally as good in real life.
Thank you both very much. Much appreciated.
I see. Start with Femi. Got your hand up.
Not to worry, my question was literally just answered with the last person, so I can put my hand down. So thank you.
It's okay. And I can't pronounce your name. EZEK.
Easy.
Easy.
It was a question on behalf of one of our deaf participants, but it was the
Easy.
Okay.
Easy. Ghanaian.
China.
So, can I ask a question?
Yep.
Yeah, so just wanted to say a question came up in the chat, sorry, that was about whether or not there's research about people who have COVID and if there are long-term effects of COVID. So I think that's a question about long COVID, and I just wondered if the panel could say something about long COVID potentially.
Yeah, I think I'll take that one. So again, COVID is a relatively new illness, and we have seen that there are certain individuals who seem to have long-term problems, be it with tiredness, being with their breathing, after having had COVID. Again, because it's such a young disease, it's very difficult to sort of make much comment on that. What I will say is that we have, certainly in this country, 2 effective vaccines which have been shown to reduce the severity of illness that you get if you do go on to develop the illness. So I think that really should be the thing to cling on to here. You want to try and prevent yourself from getting COVID in the first place by taking the COVID vaccine.
Thank you, Dr. Corrah.
There's a question. Sorry, there's a question from I think Carmen about new variants. It says, regarding the new variants, does the vaccine ensure in case we catch the new variants of COVID-19? So I think that's Dr. Corrah again.
Right. Yes, so like I think I said before that it's the nature of viruses. They change their genetic material to sort of make themselves better doing what they do, infecting individuals. I mentioned that there's 3 variants of interest currently. There's the Kent variant, there's the South Africa variant, and there's the Brazil variant. When these vaccines were designed, the template, if you like, was the original COVID didn't have any of these variants in it. But certainly we know in the UK that the 2 vaccines that are being used offer protection against the variant. And we can say that because in the vaccine studies, certainly the Oxford vaccine, the individuals who went on to develop COVID, they actually sequenced the virus in those individuals. And we certainly know that the predominant viral strain circulating in the UK at the minute is the Kent strain, and the vaccine has been shown in real life to reduce and prevent infections with that. So yes, variants exist, and yes, the dominant variant in the UK, the vaccines offer protection against it.
Another question. This one is from Mark. Does the virus attack particular blood groups over others? Dr. Perla?
There haven't been any convincing, data showing any of that. So I would say, just to keep it simple, no particular preference.
Thank you.
I see Dr. Dekreuk has had his hand up for.
Yes, thank you, Calvin. I just sort of further to one of the comments in the chat box, because I think it's important to emphasize that there is still a little bit still a lot unknown about the virus, and it's not that, let's say, everyone will catch the virus. So someone commented, I've lived with someone who had COVID-19 and I didn't get any symptoms myself. I think there is still a lot that isn't known. And also I think it's fair to say that as a sickle cell patient, you're not more susceptible to catching the virus. I think that's probably the same as in the general population, although because of shielding, the number may be lower. But I think the statement is very much that if you do get the virus, you're more likely to become severely ill. but there will still be a large proportion of sickle cell patients who have been in contact with the virus and for some reason that we don't understand yet, don't actually get ill. And I think a good example of that is that we've had quite a few patients where we, for various reasons, tested antibodies, and our sickle cell patients have a positive antibody test suggesting that they've been in touch with COVID-19, but they never got ill. And likewise, the vaccine, we offer it to everyone because we can't identify those who are susceptible to the virus and those who are not. And a sort of really stupid comparison is a little bit like with, well, let's say, for example, smoking. We know if you're a heavy smoker, you're more likely to get lung cancer, but not everyone who smokes get lung cancer. But it's better for everyone to stop for that risk. And that's sort of the whole discussion on COVID-19 as well. We don't know who is susceptible to the virus. And yes, there was, as further to Mark's question, a rumor originally that certain blood groups might be more susceptible, but as Perla already said, that hasn't proven to be true based on all the follow-up we have now. But there is probably something, either genetically or in your T-cell immunity or other, let's say, immune cells that makes you more or less vulnerable to catching the virus. That is hopefully some data that will become available over the next, well, months or years.
And let's not forget that this is not just the sickle cell disease, it's all the other, as I said, confounding factors. Yes, so there's things such as obesity, diabetes, heart disease. So there's many other confounding factors, which makes it very difficult, really, as I tried to show you when I showed you the data, to actually quantify the risk. But yes, the risk here is not. So we don't think that, as Arne said, it's not that we feel the risk of catching the virus as a sickle cell patient is increased, but it's actually catching it and making you unwell. This is what we think is higher as a risk than if you don't have sickle cell disease. So that's one of the important messages, yes.
Okay, another question from Liz. It says, if I get complications from COVID vaccine, am I signing away my rights when I accepted the vaccine? Can I still file a negligence claim? The legal framework regarding COVID and long-term health hasn't really been spoken about. Who wants to take that?
I think that's Dr. Corrah's territory. You're muted.
Yeah, thank you for the question. I think it's a difficult one to sort of answer. I mean, when you go to take your vaccine, you sign a consent form saying that you know you agreed to take the vaccine. You're told what the side effects are, and you make a choice at that point to take the vaccine. I think this is a funny area. I mean, looking at other vaccines that are around, I'm by no means a legal expert. I can't say that I can recall ever reading anywhere people suing the vaccine manufacturers for getting a side effect from the vaccine. So perhaps doesn't quite answer your question, but that's the best I can do for now, I'm afraid.
Thank you, Dr. Corrah.
Delane has asked about standard protocol if someone with sickle cell get in hospital if someone gets COVID-19.
Yeah, so I've put an answer there. So basically there is a standard of care pathway that has been changing in the months as we have got to know the virus a bit better, as you can imagine. But at the moment, when somebody comes in, it does depend on how severely ill they are with the COVID, but pretty much, so if you come in because you're unwell from the COVID point of view, you are going to get steroids of some form, and you're going to get all the supportive treatment that you need. So oxygen treatment and intravenous fluids and the analgesia. And depending on how COVID has affected you, you will get a top-up transfusion or a red cell exchange or no transfusion at all. So we have a standard of care pathway, which is pretty much, very similar to what we would do for you if you came unwell in the hospital. And then there is a clinical trials that you can enter somebody into. And of course, this will be done only once the trial has been explained to you by the ID team, so the infectious diseases team, and once you've signed a consent form.
May I jump in there as well? I totally agree. So the treatment of COVID is the same, but obviously our concern is whether because the coronavirus, because it's a respiratory virus, one of the concerns is that it interferes with the oxygen uptake, and as we all know, low oxygen tension can cause sickling and worse. One of the things I found particularly difficult / unhelpful is the sort of 111 advice that if you feel unwell, just stay at home, because that does not take into account the specific risk in sickle cell patients. And I think the one sort of life-saving measure that we have in hospital is recognize low saturations and early blood exchange or oxygen if it's a less severe situation. And I think the London hospitals, we have sort of a triage chart in A&E to sort of say if saturation low, immediately escalates, but the whole 111 pathway doesn't take that into account. And we've actually actively recommended some of our patients to buy a cheap oxygen meter if they didn't want to come into to hospital for COVID. On the other hand, my simple mind has always said, if you already have COVID, there's no harm in coming to hospital because you already got it. So you might as well come to hospital for a review rather than stay on shielding, if that makes sense.
Yes, totally agree. And also, if you remember, this is a very important message. So if you remember one of the slides I showed you, I said that in the second wave, so more recently, we had more sickle cell patients admitted in the hospital, but actually less mortality versus the first wave. We had less patients admitted in the hospital and more mortality. And that's because patients were sort of, panicking at the beginning and were indirectly told, stay at home and don't come to the, to the hospital, or at least this was the impression was given. Although from our side, we always encouraged. And so this is what we are encouraging you still now, is if you do develop any temperatures, any chest pains, if you feel unwell, do come in or call us for advice. Don't stay at home. So this is what Arne there is trying to say as well. So thank you for bringing that up.
Can I ask a question, please?
Maybe with regards to the, sorry.
Sorry, can I ask a question quickly? I know this predominantly on sickle cell, but there have been many thalassemia patients who have asked similar questions to sickle cell patients, and are they more at risk, and what are the risks and things that they should do, because it also concerns them as well as a vulnerable group.
Absolutely. We're talking here about sickle cell disease because that was set up specifically for sickle cell patients. What we have seen nationally and internationally is that generally speaking, people with thalassemia and other rare red cell anemias have not been particularly, significantly affected by the virus. So there, of course, there are patients who have been affected, and we had seen mortality, but this represents the general population risk. So does that answer your question? And there's a lot to say about thalassemia patients and which subgroups of thalassemia patients would be at higher risk than others. But unless we have a specific question from a specific patient in the audience, maybe we should leave that for another discussion.
Yeah, I just wanted to sort of emphasize the fact that because people have asked and wanted to know whether this was just going to be focused on sickle cell or was thalassemia going to be included, and I do know that there are some thalassemia patients in the chat.
Okay, perfect. If there are
specific questions, feel free to ask.
Yes. So I think if they can come forward and ask me directly the questions, both Dr. Dekreuk and Happy would be very keen to answer.
Oh, sorry, I was muted. Maybe just to come back to the informed consent question, because I think that's also an interesting one in terms of legal action. Like with all treatments, all approved treatments that we offer, generally speaking, you can't claim compensation or negligence if it was all done appropriately. So there is always a small risk with whatever you do in medicine, that you have an unexpected or rare side effect. And generally speaking, if the treatment has been done according to how it should have been done, you can't claim. But let's say, for example, if someone injects you with a COVID vaccine and they inject it straight into an artery, a blood vessel, and you end up in intensive care or worse, that's the kind of thing where you would be entitled to filing a lawsuit, etc. Or if, let's say, someone without the proper qualifications gives you the injection and you end up with complications. Those are the kind of things where you can take legal action, but not if you experience a side effect that is possible.
Thank you. Are there any other questions?
Yes, there is another question. There's a question from Titi Lola, and she's asking, does taking vaccines damage natural immune system?
No, it doesn't damage your natural immune system.
Short and sweet. Thank you, Dr. Corrah.
Okay, can I just say, sorry, Karim, I've answered your question. Yes, I'm sorry. It was meant to be, the theme is vaccination for sickle cell patients, because we have recognized the fact that the uptake of vaccination is reduced in the BAME population nationally and in our sickle cell cohort. But I would be more than happy, if you have any specific question, please do come up and ask me, or you can email me later. I'm open to any suggestion.
Dilana asked an interesting question, I think, if I may, for people who don't get the vaccine, does that mean COVID-19 will still be around? I think that's a very interesting question, because the answer is probably yes and no. Like with all pandemics, and again, I may be talking for Dr. Corrah here, but ultimately a viral infection will disappear because, let's say, the virus has done its job, or it mutates to another variant that is less harmful. And we've seen that with the Spanish flu, with the swine flu, and there are generally a few peaks, and then it gradually disappears. So what happens with the vaccine is that you interfere in the natural process. And you might have heard, especially in the beginning in the UK, there was a lot of discussion about herd immunity or natural immunity, where people build up natural immunity against the virus. Ultimately, if you let the virus do its work, the majority of the population will build up immunity, but at the price of, well, possibly 10 or 15% of the population dying as a result of the virus. And, well, you could argue whether that's evolution or not, but that's what, as a population, we try to stop. So people who at the moment don't get the vaccine, and especially if people in a close community don't get a vaccine, it means that they will still be at risk of a new outbreak of COVID-19 if someone in that community managed to import the vaccine into that community, either via work or travel or whatsoever. But once worldwide COVID-19 is no longer a problem, and that might take, I don't know, 2 years, 1 year, 2.5, 3 years, then ultimately the risk for those people who never got vaccinated will disappear. Well, Dr. Corrah, do you agree?
I was about to say, that very well put. I don't think I could have put it any better than that. Yeah, the whole idea behind the herd immunity is that if you have enough people in the population protected by the vaccine, then there's a reduced chance of the illness of the virus spreading. Therefore, the people who are not immunized will therefore not then get infection. The question, I guess, is what proportion of the population need to be protected? And there's certainly been, lots of data put out there. And the last one that I saw was that you would need something like 80% of the population to be vaccinated to offer herd immunity.
Thank you. Let's see. I think that's all the questions from the chat, unless anybody wants to correct me and have seen a question that I've missed.
I think we've answered a lot of them, but maybe Matty, we should take it up and do something separately for the thalassemia patients.
No,
if
definitely.
If there is an interest, I would be more than happy to do that.
Yeah, no, we will definitely discuss and try and organise that going forward.
Yeah.
So I just want to say thank you all so much for participating in this meeting. It was so informative. And
sorry to
Mark
has a question.
Oh, sorry, Mark.
I think UKTS did last month. They did a Zoom meeting on the virus and the vaccines.
Yeah.
So they did a similar thing to this. And they
yes, there's a lot of things going on. So if you want to set up something for our cohort again, I would be more than happy, and I'm sure Arne as well, and maybe we can get Dr. Corrah again.
Absolutely.
Yeah.
Let us know.
There might be more data by then. So
yeah, indeed.
We'll be more than happy to.
Thank you so much. So it's just left to me to say thank you, everybody, for speaking, for taking part, and for putting your questions. So I hope that you've got more information to make the right decision. Thank you.
Thank you all.
Thank you all for coming.
Thank you very much.
Safe, and thank you again. Have a great weekend.
Bye.
You too. Bye-bye.
Bye.